The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Welcome to Your Health, Your Choice. Tonight we're going to focus in on the American Diabetic Association's Conference 2020. It should have been in Chicago. We should have been in Chicago last week, but it was virtual. And we're still reviewing a lot of the presentations online and a lot of very excellent presentations on view, late-breaking research trials, etc. So I'm going to spend much of this program and the following few weeks on giving you updates from the American Diabetic Association and the European Association for the Study of Diabetes. I just want to remind you, this program plays on Wednesday night and on Thursdays at 1 p.m. And you can also look at it on Facebook and YouTube, and the various links are available. We are not live, so you can't call in as we used to do. So if you have questions, you can call. In fact, preferably, you can WhatsApp your questions on 482-4269, 482-4269. And I do try to return most of the calls, or at least WhatsApp some of the questions. Before I get into the meat of the matter, I wanted to just address, I'm not going to talk about COVID-19 tonight. We have covered that, and we know that gradually, in Trinidad at least, the restrictions are being relaxed and life is getting back to some kind of normality, or as some people say, the new normal. And, we are expected to wear masks and sanitize our hands, etc. Most public places we are going to. It's going to be interesting from this week as restaurants and cinemas and other public places reopen. But I just wanted to address the issue of metformin. I shared on my Facebook site my response and on WhatsApp to the issue of the Ministry of Health giving a circular bulletin about metformin, that certain brands of metformin had been recalled because of a chemical ingredient that was possibly cancerous. Of course, when you see a bulletin like that, I understand that there will be a lot of concerns, a lot of anxieties, and I got quite a few calls on Saturday morning. But fortunately, I had put out a response from me on my Facebook site, and I want to thank so many of you who responded and who shared it. Very importantly, we had a lot of people sharing my response. So basically, what I wanted to say to people that the particular brand of metformin, there were several brands, but it was the extended release metformin, Metformin XR, not the normal immediate intermediate release metformin or the normal metformin as you know it, that's available on CDAP or the glucophage 500 or the metformin DENK. Those were not the brands recalled. One of the main brands was the Apotex brand, but it was the Metformin XR. Now, so my response was also, so on that it was not the normal metformin that many of you would be taking, and it was the long release or gradual release metformin, Metformin XR. And in fact, the main brand that most of us prescribe is the Merck Sereno Glucophage XR. And it comes as a 500, 850, 750, and 1,000 milligrams. And that's safe. So my conclusion to that was that metformin is one of the most extensively tested oral hypoglycemic drugs. It's been around for a long time, and I said to patients, please don't come off your metformin unless you talk to your healthcare professional, because metformin can protect your eyes, your kidneys, the nerve ends, and it even has a certain level of protection over your heart. And in fact, metformin was being investigated recently as for some of its maybe anti-cancer properties. So please don't panic if you're on metformin. If you have questions about that, as I say, you can WhatsApp us on 482-4269 for further details. So I wanted to talk a little bit tonight about some important trials that have been published over the last few years. So some of these trials I'm going to talk about are not recent trials. Most of them have been published over the last 2 or 3 years. Now, one of the things about medicine that I want to tell you is that it's a constantly evolving discipline. I think, you know, the whole COVID-19 has thrown this up. The issue with chloroquine being recommended by the president of a certain country, and then scientific data coming out in one of the prominent journals saying that people had to be cautious, and then a withdrawal of some of that, and then the FDA finally coming out and saying chloroquine is not recommended for patients who are who may have COVID-19 at whatever stage. So, and some people may have got confused by all of that, because you were hearing one thing and then another thing, and then people may say, oh, it's a conspiracy theory, or you doctors don't know what you're talking about. But the way we do medicine, something that was accepted as normal practice 15 or 20 years ago, now may not be considered as optimal practice, or may even be outdated. That's the nature of medicine. That is why it is so important as doctors, healthcare professionals, we continue the process of continual medical education, CMEs, and really, as doctors, we should be revalidated and appraised once a year, and there should be a revalidation process once every few years, and that's common practice in the US and now in the UK, because medicine is an evolving discipline, and you need to keep abreast of all the data that is coming out. And some of the things I'm going to tell you tonight, you might be surprised, because you'll see how the discipline of just diabetes is changing. So if diabetes, just that one discipline, we have so much science coming out, then what about, overall, all the other areas of medicine? So that's why it's so difficult. I think being a general practitioner is very challenging, because to keep on top of all the new data that is coming out is very challenging. So the first trial I wanted to mention is the Improve It trial. Improve It trial. IMPROVE, Improve It trial. And this was a trial in patients who were post-acute coronary syndrome. So they had a heart event and they were placed on either simvastatin or a combination of simvastatin and a drug called ezetrol. This is a drug that's been around for a while, but not used as much as maybe it should have done. And there were some quite interesting results. Now, we have ezetrol in Trinidad, ezetimibe, either on its own as a 10 milligram tablet or in a combination called Vytorin. And it comes as a 20-10, so 20 milligrams simvastatin with 10 milligrams ezetrol, or 40 milligrams simvastatin with 10 milligrams ezetrol. And what this trial showed was the combination of simvastatin and ezetrol was superior to simvastatin alone in reducing cardiovascular events. That could be a heart attack, stroke, a cardiovascular disease. And the reduction was observed especially in patients who were diabetic, but of course also patients who had prior strokes or prior cardiac bypass surgery. Now, the trial started off with a lot of patients with their LDLs, that's the low-density lipoprotein. So, when we do a lipid profile, we do the total cholesterol, we look at your triglycerides, we look at your HDL, your high-density lipoprotein, which is the good cholesterol. Then we look at the non-HDL, and then we look at the LDL, which is the low-density lipoprotein, and the VLDL, the very low-density lipoprotein. And the LDL and the VLDLs are the bad cholesterols. And we used to think triglyceride was not so potent as a coronary artery disease problem. But now we understand that triglycerides are also a target. So I'm going to come to that in a minute. But the combination of ezetrol and simvastatin was able to reduce LDLs to less than 70. So, a lot of patients come in and we look at their cholesterol values, and their cholesterols may be just around 200. And someone may say, well, your cholesterol is good. You don't need to be on a cholesterol tablet. The art of doing medicine, as I say this again and again, is knowing the patient. You can say designer medicine, designing treatment for that patient sitting before you. So you look at that particular patient, at their risk profile, and I am going to have do a case presentation for you in a few minutes to demonstrate how we look at cardiovascular risk analysis and looking at individual patients. So a patient may have a total cholesterol of 200, but their LDL may be 125 and their HDL may be around 30. And that immediately tells you, especially if the patient is diabetic or a smoker or have hypertension, that they are at particularly high risk of a cardiovascular event. And you want to get that patient, most of those patients, especially if they have had a cardiac event or acute coronary syndrome, you want to get their LDLs less than 70. And in fact, in this trial, it was confirmed that the lower is better approach is the way to go with LDL. Now, there's been some controversy over that, and I know there's still some outliers out there, and sometimes people will post up on Facebook a particular doctor who says that cholesterol is not responsible for coronary artery disease. Look, with all respect, if you want to follow that advice, go right ahead. But the overwhelming evidence, and this is not about big pharma. We have all these conspiracy theories about big pharma, and let me just interject here. I know a lot of people already saying when a vaccination comes out for COVID-19, they're not going to take it. And I addressed this some weeks ago. I want to remind you again that vaccinations have been one of the most important discoveries in medicine, in preventative medicine, in the last 100 years. From the 1970s, we had smallpox being eradicated, polio almost being eradicated, TB almost being eradicated, the MMR vaccination, in spite of the scares of autism, very important, tetanus, hepatitis B. You can go on and on, all the important vaccinations. So for those of you who are already saying that you're not going to take a vaccination when COVID-19 comes out, don't blame governments if they say you can't travel if you don't take the COVID-19 vaccination. You have a choice. As I always tell people, I'm a pastor as well, the decisions we make today will determine the stories we tell tomorrow. And that applies to the COVID-19 vaccination, but it also applies to your cholesterol. So some of you, a lot of my patients, when they come in, they say, Doc, I don't want to go onto a statin because it damages my liver and it causes memory problems, etc. Can I say one of the most important interventions to prevent you dying? Yes, I know I'm being dramatic. We monitor people who are placed on statins, but the combination of Vytorin and ezetrol demonstrated that the lower the better. In fact, in some of those patients, the LDLs were less than 30. And we saw in that group of patients the best possible outcomes in terms of preventing cardiovascular disease. The second trial I was going to mention was the Reduce It trial. So the first one was the Improve It trial, and the second trial is the Reduce It trial. And this trial was intriguing because it was targeted, again, at patients. What it showed was that when patients were placed on something called IPE, now IPE or EPA, it's also called as ethyl eicosapentaenoic acid. That's a long word. Basically, it is a highly purified form of omega-3. And the trade name is Vascepa, 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 and it's a prescription drug. So I want to be very clear. This is a highly purified form of omega-3, and it's not available in Trinidad as yet. So the omega-3 fish oils that we have, you will see it's a combination of EPA and DHEA. But this particular product is a highly purified form of EPA, and what it targeted was triglycerides. And what the trials showed, the Reduce It trial showed, is that patients who were placed on that, their triglycerides were reduced, and CV events and CV deaths were dramatically reduced. Now, these were patients who already were on statins, and the LDLs were well controlled. And the addition of EPA up to 4 grams a day showed that there was a dramatic decrease in rates of revascularization and MIs. So revascularization, by that I mean having to put in stents or people having MIs were dramatically decreased. Now we know, especially in patients who are diabetic, they have sometimes good lipid profiles, but their triglycerides are high. And I'm hoping that we can get Vascepa into Trinidad in the near future. I'm not sure which company actually markets EPA, but it's a highly purified form of omega-3. And now we have evidence. Trials were done with omega-3 before, and they were shown to be negative in reducing cardiovascular events. But now we have a drug called EPA that can, from the Reduce It trial, show dramatic events, improvement in cardiovascular events. We have to go to our first break. We're already into 20 minutes. So we're going to go to our first break and return with Your Health, Your Choice. Thank you.
Cloud9 with your new hosts, Renata and Kimberly Singh. Weekdays at 5 p.m. on ACTN The Voice.
You're watching ACTN The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. You're watching ACTN, The Voice.
Welcome back to Your Health, Your Choice. I just want to remind you, this is a recorded program. We're not doing the live programs as yet. So if you have questions, you can WhatsApp on 482-4269. That's also the number for medical appointments and also the number to find out more about the church, the Trinidad and Tobago Anapostles Chapel. I mentioned 2 trials so far from the recent ADA that was virtual this year. The Improve It trial and the Reduce It trial. I was talking about the new highly purified form of omega-3 that is called Vasipa, icosapent ethyl. That's the trade name or the generic name, but the trade name is Vasipa. And we don't have it yet in Trinidad, and it is a prescription drug actually in the US. The other, and now I'm talking about cholesterol a lot because we now know that diabetes is looked upon as a cardiovascular disease, not just lowering your sugar. It's really a holistic approach and looking at the metabolic approach, hypertension, hyperlipidemia, and hyperglycemia, the 3 risk factors for cardiovascular disease and microvascular disease. There is a new cholesterol-lowering drug. They're called the PCSK9 inhibitors. And I'm not even going to worry to tell you the name of that. But this is a completely new class of cholesterol-lowering drugs. And it's a very powerful class of drugs. And in fact, they are human monoclonal antibodies. So they are not statins. They are human monoclonal antibodies, the PCSK9 inhibitors. And there are 2 that have been approved, Preluent and Repata. And they are available in the US and being used. They're a little bit expensive, but Preluent, for example, is used every 2 weeks. And Repata can be used once a month. So it's a completely different approach. But they're particularly used with people with familial hyperlipidemia. These are people with family histories that we put them on statins and we're still struggling to get down their LDLs and triglycerides, etc. And also individuals with atherosclerotic cardiovascular disease. People may have had angiograms and it showed significant coronary artery disease, and you want to get their LDLs down to less than 70, 40, 30. This class of drug is now being used to target that. Now, I just want to move on quickly to talking about 1 or 2 diabetic trials with oral hypoglycemics. And the class I'm going to focus on is the SGLT2 inhibitors, because there's a lot of buzz about the SGLT2 inhibitors and the GLP-1 agonists. Now, we don't have, we had exenatide, Byetta, and I'm not sure if it's still available, but it didn't really have a big uptake here in Trinidad, but we are waiting on things like Trulicity that a lot of patients see advertised on cable, and people get excited because it's a once-a-week drug, and there are some newer drugs coming on that are even once a month. Now, one of the trials that was done about a year or 2 ago was a Credence trial that was done with canagliflozin, and this is Invokana. That's the trade name it goes by, and it was really looking not at just lowering blood sugars, because the argument that has been used by some colleagues is that the SGLT2 inhibitors are not as powerful glucose lowering drugs as sulfonylureas and some of the older oral hypoglycemics. That is probably true. And certainly insulin is probably the most powerful glucose lowering drug. But what this class of drugs and the GLP-1 agonist is showing is that they have benefits beyond glucose lowering. So, for example, in the Credence trial, Invokana showed that the relative risk of end-stage renal failure, or doubling of the creatinine value, which is the blood tests we do to look at your renal function, was decreased by about 34%. 34%. And also, canagliflozin had a lower risk of cardiovascular death, myocardial infarction, and stroke, and hospitalizations for heart failure. So what we are finding is that cardiologists and nephrologists are beginning to take up on the SGLT2 inhibitors and the GLP-1 agonists, because they are now recognizing that in their diabetic patients, there's added benefit for giving these classes of drugs beyond glucose lowering. And probably the last trial I want to just mention was the EMPA-REG trial. And now the EMPA-REG trial was the first trial that came out that showed these dramatic results in the SGLT2 inhibitors. It was done with empagliflozin and or Jardiance, as many of you would know it by, Jardiance. And it showed that EMPA is superior to placebo in improving glycemic control, but reducing cardiovascular events and mortality in type 2 diabetic patients. But the interesting thing is this, that the trial and subsequent sub-analyses showed that it was superior not just in reducing cardiovascular events, but it also had an effect on decreasing the need for renal replacement therapy or dialysis. So it decreased albuminuria, and it also decreased moving on to end-stage renal failure. And in addition, it decreased hospitalizations for those with heart failure, those with reduced ejection fraction. So the EMPA-REG trial, and the other trial that I probably wouldn't mention was the LEADER trial with liraglutide, that's Victoza. That was I think the first one in the class of GLP-1 agonists that showed a similar decrease in cardiovascular outcomes, improvement, and prevention of cardiovascular death. Now, I know, people your head might be a little bit spinning with all of these trials, but I've done that today to show you how important it is to stay on top as someone with a special interest and looking after diabetic patients every single day, or every day I'm in my office. It's so important to stay on top of late-breaking data, because it changes the way you do medicine and your approach to patients. So even last week, having been listening to all of these seminars, my approach to some of my patients was a little bit more aggressive, not verbally aggressive, but more aggressive in my approach in trying to get patients their lifestyles, eating right, exercising, but trying to push patients a little bit more aggressively into thinking about getting their cholesterols under control, getting and pointing out to them that it's not just your total cholesterol we look at other things in addition to that, your HDL, LDL. So I'm going to go into one or two slides now. And I just want to say, over the next few weeks, this program tends to play most times for 2 weeks, and then we do another program. What I'll be doing is reviewing a slide set from the American Diabetic Association. Every year they update their guidelines, and in 2020 they did that. So I'm going to bring up the first slide, which is actually an intriguing one that I kind of updated today. This, if you look at this definition, we have often, most times, defined diabetes as based on hyperglycemia or high blood sugars. But a prominent physician, Miles Fisher, came up with this sort of redefinition, and it's not official, but it says diabetes should be defined as a state of premature cardiovascular death, which is associated with chronic hyperglycemia and may be also associated with blindness, renal failure, and of course you can go on to neuropathy, etc. So just have a look at that for a minute. It can be defined as a state of premature cardiovascular death, which is associated with chronic hyperglycemia and may be associated with blindness and renal failure. I'll just come off that slide for a minute. So you see, there's a shift in the paradigm. So when a diabetic patient comes into me, if that patient is 25 years old, okay, I may not be so concerned about cardiovascular disease at that stage. I'm going to be very aggressive at bringing the blood sugars down and concentrate on the hyperglycemia. So, the way we have defined diabetes for years is on the basis of a fasting blood sugar of above 126 or a 2-hour post glucose tolerance test of above 200 or just a random blood sugar reading of above 200, or the HbA1c of above 6.5, and very often we say that should be repeated maybe on 1 or 2 occasions to make sure, because not all labs are validated or calibrated on their machines. So, the labs need to be sure that they are constantly calibrating their A1C machines, because I've seen over the years, I've had to ring labs to query some of the A1C results that we get. So you can diagnose diabetes based on a fasting blood sugar, a 2-hour post-glucose tolerance test above 200, or just a random blood sugar test of above 200, or the A1C, HbA1c, the glycosylated hemoglobin, that should be above 6.5. However, the definition I showed you kind of shifts the paradigm significantly to defining diabetes as a state of premature cardiovascular death, not just premature cardiovascular disease, but death. And I have to say, unfortunately, I see this happening so many times. And I could give you personal examples of people I knew very, very well who unfortunately passed away in their 40s, or maybe had a first stroke in their 40s or 50s. People in their 40s and 50s should not be dying of cardiovascular events or having a first stroke. But unfortunately, diabetes accelerates the process of atherogenesis, atherosclerotic disease. And it, thanks Josh for bringing that back up. And it is associated with chronic hyperglycemia. But of course, I spent the first half of the program talking about your lipid profile. So it's associated with chronic hyperglycemia, hyperlipidemia, and not just your total cholesterol, but your triglycerides, your HDL, your LDL, your VLDL, and of course, hypertension is a big driver of cardiovascular disease and chronic kidney disease as well. I know we may have to go to a break soon, but I'm just going to bring up the second slide because this is a patient I want to discuss for a few minutes. So this is a patient, a 54-year-old Afro-American man with type 2 diabetes, hypertension. He's had myocardial infarction, and he was a former smoker. Was smoking up to 5 years ago. Look at his BMI, his body mass index is 33. That means he's overweight. His blood pressure is slightly elevated. Yes, 149/87. And I'll talk about blood pressure a bit. He's presently on Metformin, just 1,000 milligrams once a day. Aspirin, atorvastatin, which is Lipitor, and losartan, which is an angiotensin receptor blocker. And those are his labs. His A1C is 8.1. That's elevated. His fasting blood sugar was 148. creatinine is slightly elevated at 1.6. And now look at his lipid profile. His total cholesterol is not bad. It's 205, but his triglycerides are 275. His LDL is 112, and his HDL is low, 38. Now, I'm just going to come off that slide a minute, and after we go for our second break, I probably will bring that back up side by side. But I just until I get the time out for the session, I just want to bring up if we can bring up the third slide and show you what this his risk factor. So what is his risk assessment? This is where I talk about tailored medicine, or well, you want to call it designer medicine or tailored medicine. He's 54 years old, not 24, so he's already in a high risk. 54-year-old male, that's 2 risk factors. He's a type 2 diabetic, 3rd risk factor. He's hypertensive, 4th risk factor. Previous myocardial infarction, 5th risk factor, and he's a past smoker. So this patient has 5 already, just staring you in your face, risk factors for another event. Some of these risk factors are what we call non-modifiable. So he's male, we can't change that, although some people may want to. His age, can't change that. He's a past smoker, and he's had a past MI. Those are non-modifiable. What are the modifiable risk factors? His diabetes. He has chronic kidney disease, so you could add that as a 6th risk factor. He's hypertensive. Obesity, you can add that as a 7th risk factor. His dyslipidemia is up to 8th risk factor. So this man has 8 risk factors so we can just come off that slide now. This man has 8 risk factors for another cardiovascular event. Now, when this patient comes into us, you can't see him in 5 minutes. This patient, especially if it's a new patient, he needs about 30 to 45 minutes consulting, talking, taking a careful history, then looking at all the risk factors that we have outlined. Hopefully, he would have come in with his labs as I've presented to you. But of course, a lot of first-time patients don't come in with labs. And in fact, I'm constantly surprised by diabetics who come into me for the first time. And I say to them, when last did you have a blood test, a lab test? And they say, 5 years ago. And they could see the shock on my face, because you cannot do diabetes properly by just a finger prick test. At least once a year, and maybe every 6 months. And the American Diabetic Association says if your A1C is elevated every 3 months, you should have an A1C assessment. But at least every 6 months, you should have your A1C done. Your lipid profile, depending on what it is, you can have it done once every 6 months or once a year. Your creatinine, if you have chronic kidney disease, you need to have your renal function done at least every 3 to 6 months. And now a lot of the labs are doing something called your estimated GFR. Your GFR is your glomerular filtration rate. So you would notice that guy's GFR was 56 or 57. That's established as chronic kidney disease 3A. So early chronic kidney disease, but nevertheless chronic kidney disease. We didn't have a microalbuminuria test on him, but I'm sure if we did microalbuminuria, it would have showed to be positive. And microalbuminuria is, of course, a marker for nephropathy, kidney disease, but also for vascular disease. I'm going to come back and discuss this patient in more detail, but we're going to go to our second break on Your Health, Your Choice. Thank you for viewing. Stay tuned.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. You're watching ACTN The Voice.
Exclusively on ACTN The Voice. This is Messenger TV. Join us as John and Lisa Bevere equip and empower generations of Christians, both young and old, developing uncompromising followers of Christ who transform our world. Starting on Mondays at 8 a.m. with repeats to fit any schedule. Tune in, log in, or click on the Word like never before. Stay tuned for a new experience from the Word of God with Messenger TV, exclusively on ACTN The Voice.
Welcome back to Your Health, Your Choice. We're talking today about updates from the American Diabetic Association 2020 virtual conference. We should have been in Chicago, but we were viewing online. And I gave you some trials that were discussed, that were published before, but brought back to the ADA this year. The Improve It trial, the Reduce It trial. I told you about the PCSK9 inhibitors, a new class of cholesterol-lowering drugs. It's a monoclonal antibody, a different drug to the statins we have had. I told you about Vascepa. It's a highly purified omega-3. It's a prescription drug in the US. We don't have it yet. I want to just say that it's not the omega-3 fish oils that we have available in Trinidad. And it showed that reducing triglycerides can have a significant effect on preventing cardiovascular disease. And then I talked to you about the Credence trial with Invokana, decreasing end-stage renal failure, and the EMPA-REG trial with Jardiance, decreasing three-point MACE, myocardial infarction, strokes, and also giving evidence of preventing hospitalizations from heart failure, especially those with reduced ejection fraction heart failure, because you can have heart failure with maintained normal ejection fraction when you have right-sided heart failure. And that's actually quite common in diabetic patients. Then we talked about the LEADER trial. And then I came down to discussing a patient. So I don't know if we could have the dual screen again with that patient's details, because what I was showing is that this patient had about 8 risk factors for a subsequent cardiovascular event. So I think it was slide 2 that we had showed, and thank you, Josh. So if you look at this, the patient has poor glycemic control. His A1C is 8.1. The A1C should be, especially someone who have had a heart attack already, a myocardial infarction. Let me just say, once you have had one myocardial infarction, you're at risk of subsequent cardiac events. The same thing with strokes, so TIAs, transient ischemic events are not innocent. Those are not full strokes, so we call them mini strokes. But once you have had one, you can have subsequent ones. So his A1C is high. His blood pressure is not ideally controlled. I think it was 148/97 or so. And his lipid profile is also abnormal. His triglycerides are high. His HDL is low. And his LDL is 112. Someone with a previous MI in a diabetic, I would be trying to get that LDL down to less than 70. I want to get his triglyceride down to less than 150, and I want to try to get his HDL up. So I'll just come off that slide to the full screen. So this patient is going to come in, and we're going to talk about lifestyle first, because he's overweight. His BMI is 33, depending on when his MI was. If it was only a few weeks ago, I'm not going to rush him into an exercise program. But if his MI was 1 year ago, I'm really going to emphasize that he does need to get into some sort of exercise regime where he's doing a cardio workout with some resistance training, 30 to 45 minutes at least a few times a week. And I know a lot of people are getting back into exercise with the COVID-19 relaxation process going on. The gyms are being reopened. But let me just say, personally, COVID-19 worked well for me in that I developed an exercise regime for at home. So I'm not saying don't go to the gyms, because you may need a personal trainer. But if you are self-motivated, and one of my colleagues was showing us on our WhatsApp reunion site, Dr. Pottinger, I'll call him out. He's a good friend, a gynecologist based in Port of Spain. He has a personal gym at home, and he was showing us last night on our WhatsApp site his home gym. And boy, he's really exercising. He inspired me to be doing a little bit more. So we can develop regimes for us at home, which it becomes part of our lifestyle. We often say a habit, good or bad, is something that you repeat for about 30 days, every single day. So it might be praying, it might be reading your Bible, it might be exercising, it might be eating healthily. You repeat it often enough, and it becomes a part of your life. So you can develop, you have a choice. You can develop good habits or bad habits. It's up to you. So after we talk about lifestyle, and that's why this consultation is not going to take 5 minutes or 10 minutes. It's probably going to take about 30, 45 minutes. Then we have to talk about medication. So he's only on glucophage, so I'm metformin. So I'm surprised that he's only on metformin with an HbA1c of 8.4. I will not be going for sulfonylurea. And the new guidelines are emphasizing that while sulfonylureas bring down the A1C, the longevity of the effect, what you see is a wearing off of the effect as you go to 4 or 5 years. And now we have evidence that the SGLT2 inhibitors are particularly, and the GLP-1 agonists are very, very powerful drugs, not only in per se reducing blood sugars, but giving you cardiovascular protection and renal protection. And remember, his creatinine was 1.6. So I would be probably wanting to add in, I would not go straight for insulin, because the problem with going for insulin in this man is that he may put on even more weight. We may bring his blood sugars down, but his weight may go up. I would definitely be looking at either Jardiance, Invokana, or Forxiga, adding that in for his blood glucose control, but giving him cardiovascular and renal protection. What about his hypertension? Well, for his hypertension, he's on losartan, which is an ARB. I can't remember what the dose was, but we can either increase that dose, or we may need to use combination therapy. So you may want to combine the losartan with a calcium channel blocker, or with a thiazide-like diuretic, something like Natrelix. So we have now combination drugs. So I definitely, if the problem is sometimes people come into the doctor's office and their blood pressures go up. So you want to ask the patient to do their blood pressures at home. And I give my patients my telephone number, and I ask them to WhatsApp me their blood sugar results or their blood pressure results. And if it's elevated over a period of time, or if I review them in 2 or 3 weeks and it's still elevated, I will then be wanting to add in a second antihypertensive. And then what about his hyperlipidemia? Is his high cholesterol. I said that his total cholesterol wasn't bad, but his triglycerides were high, and his HDL was low, and his LDL is 112. Now, I would encourage him to exercise. If he could lose about 10 to 15% of his body weight in about 3 to 4 months. So I don't go for the crash diets. I don't go for the ketogenic diets as well. I would go for a low carb diet with good protein intake, the lean white meat, better than the red meat, and a certain amount of fats, saturated fats. And I know that's a little bit controversial, but there's some new evidence that it's not as bad as we thought it was. Now, I'm not talking about fried chicken and all that. I'm talking about lean cuts of meat. but decreasing your carb intake. And remember, you want to move to low glycemic index foods, low GI foods. You can Google that, low GI foods. And of course, like the multigrain whole wheat bread or the brown rice or basmati rice. Ground provision is lower GI than white flour and white rice. So lots of vegetables and salad, either, the tomatoes, cucumbers, things like that. But you could have cooked vegetables, carrots, zucchini, all those things. And so you make it more edible. So what about his lipid profile? What would I choose? Well, I would not go just for simvastatin. I would go for a combination drug to try and get his triglycerides down as well as his LDL down. So I would probably go for a drug, maybe either high-intensity statin like Crestor or Lipitor at 40 milligrams, together with Ezetrol. But there is a combination of simvastatin and Ezetrol in one drug, Vytorin. So that might be an option if you want to decrease the pill burden. And if we had Vasipa, if we had that highly purified form of omega-3 EPA, I would certainly consider adding that into this patient. So this patient is going to come in, and we're going to have to change a lot of his drugs. It's going to take a little bit of negotiation. If it's the first time so what I try to do, if it's the first time somebody is seeing me, I try not to bombard them with all the changes, because often for a patient to change action or to change drugs or to change lifestyle, it takes a certain level of trust to be built up between the doctor and patient, and that comes over a period of time. So the doctor-patient relationship is very important. And I found myself last Saturday seeing quite a few patients who I emphasized that their diabetes was not just about the physical entity. It was not just about lowering the blood sugar, but it was about their mental state. So, for all of you listening or viewing this on Facebook tonight or subsequently, I want to remind you that diabetes care and your health care is not just based on the physical entity, your emotional and mental state. In fact, I had one patient on Saturday who admitted that he was mentally very low, and he was drinking excessively. I think he has a low self-esteem, and just looking at his numbers would be missing a lot of the pathology that patient is presenting to you with. So I spent some time talking about his mental state. Even sometimes you have to suggest someone seeing a counselor or psychologist, and I know there's a stigma often attached to people talking to someone. They might say, well, I have diabetes, I'm not mad. And I detest the word mad, because there's just so much stigma associated with that word. The reality is, I shared with our church yesterday morning and the few days leading up, I was feeling a little bit down leading up to Father's Day. Why? Because my two children are away. Yes, they're grown up, 32 and 21, but both in the UK. And I was feeling a little bit sorry for myself. And I was not depressed, but mentally and emotionally, I was struggling with that until I, of course, spoke to them on Father's Day. And we spent about an hour talking. And I just talking was so uplifting. I see that we are probably going to have to wind up. So, we have been talking, we have about 3 more minutes. So just to summarize, and in the next program, I'm going to come back. Particularly, I felt I wanted to do the patient case presentation, because I've not done that in the past. And what I've tried to demonstrate to you is why diabetes is for me, such a fascinating subject. It's not just about lowering a blood sugar anymore. It's about looking at the person from a holistic point of view. That particular patient I showed you, they had multiple comorbidities, obesity, hypertension, diabetes, previous MI, hyperlipidemia, chronic kidney disease, past smoker, past MI. That's a bomb waiting to go off. And it takes a lot of effort trying to get that person to a point where you decrease all their cardiovascular risk factors as well as controlling their blood sugars. If you have questions of what we have talked about, you can WhatsApp us on 482-4269, or you can, those of you who are on my timeline on Facebook, you can inbox me with your questions. Claude Khan, I think you might have to ask to be invited onto my timeline. And also, you can email me on claude_khan@yahoo.co.uk. I put my pastoral hat in ending. I just completed a series. We had a guest speaker for Father's Day yesterday, but just before that, completed a series on making decisions, divine direction. And many of us need divine direction. And the last sermon I preached was talking about sensing the Spirit's nudge, the Spirit's prompting, and being willing to walk in certain uncertainty. I used Acts chapter 20, where Paul was leaving Ephesus to go to Jerusalem and not knowing what was waiting for him there. But he knew that he was going to be in jail, so he was going to face predictable resistance. Can I say to you as I end today, resistance is not evidence that you're not following the plan of God. In fact, when you face resistance in your life, and it might be in your career, it might be in a ministry calling in your career or in church, very often resistance is a good indicator that you are right where God wants you to be. Resistance will build up your spiritual stamina so that you can stay the course and you can fulfill the call of God upon your life. In fact, if you're not ready for resistance, you're not ready to be involved in the work of God. I want to thank you for joining us on Your Health, Your Choice tonight. This program will be replayed, and you can contact us on 482-4269, and we'll return with another new program in about 2 weeks' time. Thank you for joining us. I'm Dr. Claude Khan on Your Health, Your Choice.